a weird case, but that's kind of our specialty, so to be expected. We have a 33-year-old male, has been in Suboxone clinics before. He's just got out of Jacob's Ladder, 6 months long-term rehab. Got out in September, came to us in February, wanted to restart buprenorphine, was off of it while he was there, was started on Prozac while he was there, and has not been on it since. Has only been able to maintain a few days of sobriety at a time. He says that now he has more motivation to stop using, as it's getting harder for him to recover from things as he gets older. And he also thinks that he's going against the path that was laid out for him. One issue that tends to pop up, especially after methamphetamine use, is he starts to become a bit of a theologian and comes up with some very wild theories that he starts to fixate on, which also kind of drives him further into use and also away from any kind of recovery capital things, as he spends more time doing research on his new theories than he does attending meetings or doing therapy. Right now, he says that one of the biggest influences on him using is people around him using. And we kind of have a speculation that it might be his significant other. He has a history of manic depression and ADHD, substance use with opioid, stimulant, other psychoactive, and cannabis use. I think that going to detox to kind of clear methamphetamines out of his system would be good, because we've noticed that he's been in our clinic before. We have noticed that when he has at least a week or so off of methamphetamines, that these fixations and theories start to go away. So I think the more we could kind of capitalize on him not using and not going down that weird rabbit hole, that he would be better off. But he has a job right now that's probably the most stable he's had in a long time, so it would, I think, put that at risk. He does have an allergy to animal dander. Like I said, he's off the Prozac. He started on 12 milligrams of buprenorphine when he came back to us, and I think it was bumped up to 16. And then we did Brixadi with him for 3 weeks with a 1-week dose. He said it was wearing off around the third day, and he said he liked it, but I have a feeling that Brixadi might not be the best option for him, because what he likes from the Suboxone is that initial spike from having the buprenorphine in his system, as he tends to take it when he starts to get more anxious or feels like he needs something. And then he tried to argue with us that the 24 milligram dose of 1 week Brixadi only comes down to like 3 milligrams a day. And I told him that you can't break it down that way, but he got very confused by the whole thing. And as far as like requests, I had no clue where to start with questions on this one. I was just, I don't know, let y'all kind of ask me more questions or tell me what you kind of see popping up here.
Thank you so much, Derek. All right, any questions or comments, or just chime in?
Is it a significant other in treatment?
Not currently. She was. I think she got out around the same time last year.
So it's going to be tough with that kind of recovery environment. I don't know what you can do really, unless you can get them aligned, both kind of in interest in taking care of themselves.
Yeah. He had first kind of placed it on his upstairs neighbors and said that they were getting him to use or offering to him. But when he first had a relapse that brought him back to us, both him and his significant other relapsed at the same time. And I think it's kind of hitting her a lot harder than it is him, which is then hitting him like secondary. But he's never explicitly said it's her that's getting him to use now.
Derek, first of all, thank you so much for presenting this. I maybe missed this. Is she currently in treatment also, or just him with you guys?
She is not in treatment with us.
Okay.
I don't think she's in treatment somewhere else.
Okay.
At one time, I believe she was at Chestnut Ridge, but I don't think she has maintained that.
Gotcha.
Yeah.
Yeah, I agree with Dr. Hirschler's perspective of if you could get that family support, either her support of him going to treatment or for her kind of getting in help at the same time. And sometimes it's inviting family members in for a session under the guise of
Yeah.
how can we help you all collectively as a unit, may or may not help.
I think that'd be a good idea. I think if we can get both of them to agree to that. The confusing thing about it is she used to be a huge support for him because she would kind of keep him on track with things and even would get really mad at him if he did relapse. But
Yeah,
now it's starting to sound like it's
flip-flopped.
flipped a little bit. Yeah.
So
I like to
Derek,
ask. I'm sorry. Go ahead. Go ahead, David.
oh, sorry. So his bipolar disorder, what's that diagnosis based on? Because a lot of people have just stuff on their chart. And has he been treated for that with any other medications? Because that may be helpful too, even though it sounds like it's the stimulant that's triggering things, but he could also have some underlying other psychiatric disorders, whether OCD or, bipolar or, schizoaffective and stuff.
Yeah, I've been questioning that because that was something he self-reported in his history, and we've been able to find nothing related to it.
I was just going to say,
Mine's-
I like to ask patients what success looks like to them. If he has some kind of view of the future of a better future for him, that discrepancy can motivate change.
Yeah. And he has good ideas of what his recovery would look like. He wants to stop using everything. He wants to be more level-headed. He tells me he doesn't like the way stimulants especially start to mess with his vibrations and how it messes with the way he perceives the frame rates and hertz of different Xbox or PlayStation games. But also the recovery time, like from using, he says it's kind of getting to him, especially with his body. But he tends to dismiss a lot of things when he gets very fixated on these theories.
Good question. All right. About when did he initiate substance use? When did he begin?
Earliest thing was 14 with nicotine and then 15 with alcohol. Rest of it is around 16 or 17 with opioid stimulants, cannabis.
Okay. So from even before some of these diagnoses would have presented, he was using substances that mimic or will
Right.
induce mania, or even because that's some odd belief there, but the hertz and how he experiences that. And
Oh,
that
yeah,
only
he said
that only crops up with the methamphetamine use and then it resolves with sobriety, or is that always there?
it does resolve with sobriety. I mean, I think it's always kind of in his head and it's something he thinks about, but he doesn't get as fixated on it. And kind of every year he has a different overall theory that tends to drive him. Right now it's about breaking down the bloodlines from Adam and the serpent, and only 44,000 souls come from Venus, and they're Venetians. You can tell by the V on their forehead, and people who have a positive blood type give off positive energy. People with negative blood type give off negative energy.
Okay. A little, schizophrenic-ish sounding, with some very
Yeah.
odd. Yeah, because I mean, especially if he has an underlying problem, an antipsychotic might kind of hard to know which came first, the cart or the horse.
Yeah,
It is hard
but
to
would it
tell which
make
came
sense
first.
to-
And go ahead, David.
would it make sense to try an antipsychotic even if it is compounded by his use? Just because those are pretty out there, and he'd have to be using a lot of meth all the time, and so maybe that's, but I would consider trying a mood stabilizer on him.
Who does the prescribing, Derek, of there? Like, would they be able to have access? Like, Vraylar is one that's been thrown around a little bit lately for methamphetamine use and psychosis, cariprazine. So I don't know if you'd have access to that, or if you have to go like older school Seroquel or Abilify or something of that nature. But it's a pretty reasonable way to go about it.
Yeah.
The
I
other
think
thing
we'd
is,
be able to do those things. I think it'd be more so convincing him to do it because he kind of sees this as something he like truly sees as I don't know, a part of his
yeah.
his path from God.
The way I sell antipsychotics to patients who are delusional and believe firmly in their delusional beliefs is to say that this medicine will help you not worry about these things so much. I'm not saying that
That's good.
it's an illness necessarily, but you just won't be worrying about it quite as much.
Yeah, that's good. Good idea.
I
Yeah,
found
just-
that helpful as well. Yeah, not to challenge their conclusions as much as their distress that's associated with
Yeah.
it.
Yeah. I normally don't have to think about these things because I'm not a prescriber and I'm anti-big pharma, but I'm okay with Dr. Husted.
Thank you. I'm not big pharma, trust me. uh, I hate those. Well, I was going to say a bad word, but
Whoa,
we
keep it
recorded.
easy,
So.
guy.
The
Well,
other
it's
thing,
rated G.
yeah, I
Yeah.
taught
Your team.
myself.
No,
I've felt
these
it.
are good ideas of trying to sell the idea to him. What were you
Did-
going to say, Dr. Husted?
I was gonna say, is the intention to keep him on weekly Brigzotti, or are you trying to transition him to monthly, or what's the idea with that?
Being that he has the continuous relapses and that it's inconsistent with his attendance on things, we wanted to keep the weekly level until we could like get his consistency up more.
I will say with the weekly is if he's reporting it wears off after a few days, that is a thing with Brigzotti. So the carrier that they use is very different. So they use like an alcohol carrier in the weekly shots. So there are people that will report it leaves their system fairly rapidly. So with the monthly, it's a whole different carrier, and it forms like a little crystal structure, or so they say, under your skin. It lasts a lot longer. So there could be something to it, not just him wanting like to feel a certain way, but it may just not honestly last long enough in his system as the weekly shot. So it might be worth at least considering giving him the monthly. Still expect him to be seen regularly, but that may help a lot with his
Yeah.
from an opioid side. So
Well, I was thinking also like a monthly of the Sublocade because I know that initial injection is a lot higher.
well, it is, but I mean, it's really the equivalent. So a monthly of 300 of Sublocade is the same as a monthly of Brigzotti 128 in terms of your body's not going to discern it. He might go for it because it's a bigger number and he thinks it's more, but the reality is the blood levels are going to feel exactly the same.
We tried to have a whole education on the blood levels and then it didn't really take with him.
Then do Sublocade.
Yeah.
See what happens. Yeah.
And we've had some patients even then, struggle with being on the Sublocade. And I don't know the exact, they didn't feel it was holding them, even, kind of tapering them and overlapping them. Are his relapses meth or opiates or both?
Right now, just methamphetamines.
Yeah, so maybe it's best to target, keep them on whatever it takes to get them connected and off the opiates and work on the meth and the psychiatric issues, as a way, to get off the meth, like I said, sell that to them potentially.
Good idea.
You said he's liking his job.
He does like his job, yeah.
And
He
so
works in
is he
Nashville.
motivated for that reason alone to get some more purpose and meaning out of his day-to-day work and to be contributing and reaffirmed as to his place in the community? And
I could probably, yeah, kind of motivate it in that direction.
getting some attaboys sometimes
Yeah.
motivates a person to help with that.
Go ahead, Sarah.
Hey, Derek.
Go ahead.
Yeah.
Hey,
Hey, Derek.
Sarah.
Hi. So real quick, you might have covered this and I came in a few minutes late, but what kind of social interaction does he have outside of the girlfriend? So because that sounds kind of like, the conspiracy theories and stuff like that. If that's being reinforced reinforced by like maybe some social interaction online, because you mentioned online gaming. I just wonder like if that's being reinforced somewhere and then tied in also with the methamphetamine use. So I wonder what kind of social interactions he does have out there.
I don't think many, because we've tried to, and he's done a good job on his own of like steering away from people that he used to use with, or always encourage him to use outside of his significant other. I could definitely see how some of his past associates would reaffirm that. I don't know about his girlfriend though, if that's something that she kind of buys into or encourages or reinforces. I think sometimes she does, but other times I think he's mentioned before of like she just looks at him like he's crazy or yells at him.
Have you ever tried to interact or intertwine some DBT with him, like discovering like what are facts, what are things that we can, because you're not going to be able to argue necessarily like the V marks or the blood type or anything like that. But I wonder like how can we keep him mindful in the moment and also connected with what the facts are and what he can and can't control, and maybe even play in some radical acceptance with that.
No, I haven't made it to radical acceptance with him, but I've done a lot of like grounding techniques or getting him to be more like discerning of things that he can and cannot control. Sometimes it's effective, sometimes not. Like I said, when he's not using, those things are a whole lot more effective. Sometimes even after just one relapse with methamphetamines, it's like he's back full force. Like I said, the past couple weeks, he's spent most of his time just doing research and learning more about the bloodline of the serpent versus the bloodline of Adam, and how he thinks that his bloodline is part of Adam's, and something about the Venetians. That one started to get lost on me.
Yeah, that makes it hard too, because he's literally just kind of putting himself in that echo chamber where these kind of theories get spread around and spinning. And so like if sometimes it is a big part of just education on how do we critically kind of think what we believe versus what we don't believe. But it's hard when you're in that echo chamber. So I feel your pain.
Yeah. I've been lucky that this go around he does have that motivation to stop because of how it's affecting his body and his health. So I've just been leaning on that. I know like a year ago it was a lot harder because he would tie his use into his spiritual beliefs. That it opened his eyes and made it easier for him to see things. So that part is getting a little easier, because anytime there's a little bit of motivation on their own, that can be capitalized on.
Yes.
It's just the inconsistency of where his mind's at is troublesome.
Excellent. Thank you so much. Does anybody else have any final comments, just for the interest of time, so we can go to the didactic? Thank you again, Derek. Really appreciate it. And if you need to reach out,
Thank you.
please reach out. All right. Are you ready? Jessica, you can go ahead and introduce yourself to the group. We really appreciate your time. And then just let me know when you're ready for me to share the slides.
Yeah, absolutely. I'm having, as Elizabeth knows, I'm having some technical difficulties, so she's going to share the slides for me. It's great to be with you all. I really appreciate the opportunity to speak with you today. My name is Jessie Merlin. I'm a physician. I trained in internal medicine, and also after that trained in infectious diseases and palliative care. And that's how I found my way to addiction medicine. I was originally an HIV primary care doc, and got very interested in pain and addiction through that, and really focused. I was drawn to research because I felt like there are so many unanswered research questions in that space. And now I'm primarily a researcher at Pitt that focuses on the intersection of pain and addiction across populations and settings. And I also very active clinically. I work in our internal medicine recovery engagement program. So I treat patients with addiction, particularly those who have pain and also have serious illness, particularly cancer. So I realize I'm in a room with incredible expertise. I really enjoyed that case and the discussion. So I hope that this can be an engaging conversation. I have slides, obviously, but I will be keeping an eye on the chat and hope that we can kind of have a little bit of a back and forth. I'm totally fine if I don't get through all my slides because there's so much to talk about. That would be fine. So with that, I will go ahead and get started. So what I'm hoping to talk to you about today is chronic pain in patients who are on medications for opioid use disorder. And I came to this invitation today because I have my connection to West Virginia is that I am collaborating with a bunch of folks at WVU on a study that really focuses on helping to figure out how we can best care for patients who have chronic pain, who are in opioid treatment programs, who are being prescribed buprenorphine for their MOUD. So here's what I'd like to talk about. We'll talk about why this topic matters, just some key terms and concepts in pain. So, obviously folks come from an addiction treatment background, but people may have more or less familiarity with some pain concepts and terms. And then we'll talk about evaluation of patients with pain and addiction and management. So next slide. So we can do a little show of Zoom hands. How common is chronic pain in your patients or your clients who are on medications for opioid use disorder? Do you think it's very common? Let's put it this way. Do your patients have chronic pain who are on MOUD? It's maybe the better binary question to ask. Raise your little Zoom hand if your patients have. Yes, or give me a thumbs up. Just one thumbs up. 2, no chronic pain? Really? I wonder if we're just not asking the question. Yeah, very interesting. Well, not super common, but happening. Okay. So maybe not super common, but happening. Any other thoughts? People can just throw it in the chat, or you can unmute yourself if you'd like. I know there's some chronic pain expertise in the audience. There you go. So somebody who knows the statistic. So next slide, please. You're setting me up perfectly. Yes, I got a yes. That's good. Next slide, please. Okay, so this is a great systematic review from just 2 years ago. 23 studies, and these are in clinics that focus on methadone or bupe for MOUD, and some that are mixed. And yeah, the prevalence in this study was basically exactly, thank you, Dr. Hirschler, exactly. So basically 40 to 60%. So it's very, very, very common. And I think just like anything else, if you don't screen for it, you won't know that it's there. And, back when I started doing this work on chronic pain in people with HIV, I would get this, very frequently, like, oh, it's not that common in this patient population. And it was sort of like back then we just weren't screening for it. So, I think that, sometimes is the issue, right? And just some additional interesting information from that paper. No difference in rate based on whether people were being prescribed methadone or bupe, or gender. So, why is this important? So, I mean, I think things that are common in our patient population are obviously important. We like to address common comorbidities, but and I think pain in and of itself. I mean, I started off primarily a pain researcher, so obviously I think pain is important because it impacts important things, right? Like quality of life, ability to work, ability to focus on other chronic conditions, because people are prioritizing pain over them. but in particular, the ability to focus on opioid use disorder, right? So what is the relationship between pain and opioid use disorder, and how does pain impact opioid use disorder outcomes? So I think that is something that, you know, if nothing else, is a really important question. Next slide. So I really like this model. This is from my colleague, Joe Dietrich. And he proposed this reciprocal model of substance use and pain. And what he says in this model is that individuals who have substance use, and we can just substitute opioid use for this in our, you know, our area of interest, that substance use, you know, substances may be used in people with chronic pain because they're trying to acutely make their pain better, right? So even, you know, not just opioids, but we know, you know, people who use opioids also may use cocaine or methamphetamine, like the person in the case that we just saw, to help alleviate their pain. In the short term, it may help, even though in the long term, it may make things worse. But when they stop using that substance, they may have abstinence-induced hyperalgesia, right? Certainly with opioids, we see that happening. And we know that substance use just statistically increases people's risk for developing chronic pain. And then there are impacts of pain on substance use, right? So again, use of substances to cope with pain, and then pain becomes a barrier to cessation, right? And then that kind of perpetuates the cycle of pain becoming a risk for developing a substance use disorder. And then these things kind of mutually reinforce each other, right? So that you have this maintenance and progression of both chronic pain and addiction at the same time. And this can really be with any substance, but again, we're really, you know, it makes a whole lot of sense in patients who are using opioids. Next slide. And I think this is such a great point in the chat, Kathleen, that some of our patients don't self-disclose because of stigma, right? So, and I'll talk about this in a hot second here, but, you know, there's chronic pain stigma and opioid stigma, right? And how those play out in our clinical setting, I think is very unique. So I'm going to get back to that in a second. Chronic pain in our patients is often not treated, maybe because we don't know about it. Here's just some statistics about this. So in one study of a large number of patients engaged in an MOUD program, most reported no pain management. And of those who reported pain management, most of them reported biomedical pain management, which when you drill down into it was just the buprenorphine or methadone they were receiving, which, you know, may or may not actually be managing their chronic pain. We did some work in a large database looking at physical therapy for chronic pain, which we found was underutilized in people with opioid use disorder. So just like with a lot of things, our patients just receive less evidence-based treatment. Next slide. And in the same study, in a very small subset, you know, some evidence that people who were not being treated for their chronic pain experience a return to use, of whom half cited pain as a trigger. And I think we see this clinically, right? So when people are having more pain, you know, stands to reason, they're going to look to the substance to help with their pain. That's going to trigger a return to use, whatever the substance, but certainly for opioids. Next slide. So what are the risks of not treating chronic pain in patients with MOUD, who are on MOUD? So we know that pain is negatively associated with retention in methadone MOUD. So you would imagine if you treated pain, that might help. Chronic pain increases the risk of overdose. And the risk goes away in individuals who don't have symptoms in the past month. Again, stands to reason, maybe treating chronic pain may help. Next slide. I think I may have missed a slide there, but that's okay because we got to keep going. Tight on time. So, and I think, you know, the question is, if not us, who, right? Because a lot of our patients, you know, as you know, we are their doctors, right? So like they may not be seeing, we are their touch points with the healthcare system. They may not be seeing anybody else. So if we're not going to be the ones treating their chronic pain, who else is treating their chronic pain? Do they have a PCP? If they have a PCP, their PCP is probably not that comfortable treating their chronic pain because they have an opioid use disorder. So, you know, then again, it comes back to us. So these are our patients. We have the skills, addiction and chronic pain skills. so similar. We can do this. So let's jump right in. Next slide. So a couple key pain terms and concepts so we can get right into the management. Next slide. Okay. So first, acute pain, normal predicted physiologic response to an adverse stimulus associated with surgery, trauma, acute illness, minutes to months. Next slide. I say that so we can define what chronic pain is, which is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. So realizing that not everybody with chronic pain has tissue damage, right? Some people do and some people don't. And some people have initial tissue damage and they may not have ongoing tissue damage. So think about somebody who has an initial trauma, and this is really common in our patient population, right? Like an orthopedic trauma. And they, they have that broken leg, and some people are going to recover from that broken leg just fine, and they're not going to have chronic pain, and other people are going to recover from that tissue injury just fine, and they're going to be walking and doing all right, but they're still going to have that persistent pain, right? So, and even though that tissue damage is not ongoing, they still have the persistent pain. And then you have people who don't have any initial tissue damage, like folks with kind of non-specific low back pain, fibromyalgia, what we call chronic widespread pain, which is basically like fibromyalgia, but with a lot of those somatic symptoms. And yeah, they don't have any of that initial tissue damage, but yet they still have chronic pain, right? So we define this as pain lasting at least 3 months. It's really common in the general population. So the latest stats on this from the CDC MMWR from 2023, 20% of the general population has chronic pain. So when I give a talk like this, I realize that there's probably somebody in the audience who has chronic pain, maybe, definitely somebody in the audience who has somebody close to them with chronic pain. 6% of the general population has what we would call high impact chronic pain, so significantly impacting their function, quality of life. And chronic pain has a unique neurobiologic basis influenced by biological, psychological, and social factors. So I'm not, obviously this is a really short talk, I'm not going to go deep here, but just recognizing that chronic pain really is a disease in and of itself. It's not just a symptom. It has a unique neurobiology, and it's also influenced by psychological factors like psychiatric comorbidities like depression, anxiety, substance use disorders, and social factors like social isolation, things like that. Next slide. Yeah, so I've already said it. Chronic pain is a chronic disease in and of itself, and the optimal treatment is multimodal treatment, including pharmacologic and non-pharmacologic treatment in a multidisciplinary setting. We generally in the US do not get to do this. We are usually hodgepodging things together, but there are things that, certainly are things that we can do that are evidence-based for our patients. Next slide. Evaluation, just briefly, next slide. So chronic pain history, focus on function. So in chronic pain, we've gotten way past the 0 to 10 scale and just leave it at that. We care a lot about 0 to 10 function. So, and really the way that this plays out for me is that I like to ask people, how do you spend your day? In addition to, standardized questions about function. And also mood and sleep. So I like to understand, some people tell me that pain really impacts their mood, such that, like when they have really bad pain, they feel really down. And when they feel really down, they have really bad pain and they kind of get into a cycle. Have you ever had something like that happen to you? And a lot of, there's so much comorbidity between pain and depression, anxiety, etc. People really understand this. And then pain and sleep, because if you don't ask about these things, you won't find out. And treating these things is really important. Next slide. Diagnostic testing, evidence-based judicious use is best. Pain may not have something light up on a blood test or a radiograph, and that's a challenge for both the patient and the provider. It's very okay to suggest that a patient go to a PCP for this and work on management at the same time. So if you think that somebody needs a workup that is beyond what you want to do, that's, I think, okay in this setting. But most of the time, chronic pain does not require a very extensive, a very extensive workup. You don't want to miss something, obviously. So if you know, for example, like, you know, older adult chronic pain, you know, you don't want to miss, you know, a metastatic lesion or something, but at the same time, you can work on that while also working on their chronic pain. And I'm happy to talk more about that. Next slide. Okay, management. We have already hit on chronic pain stigma, and I'm so delighted that somebody has already brought this up. So stigma, a mark of shame, disgrace, or disapproval that results in an individual being rejected, discriminated against, and excluded from participating in a number of different areas of society. So we all know, live, breathe OUD stigma and understand that, you know, our patients, when they go into other parts of the healthcare system, they get this, right? And they get this from society, from their families, at the drugstore, you know, at the pharmacy. This is so much of their experience, and it absolutely impacts the way that they interact with us, right? And then when they have chronic pain and they have experienced chronic pain stigma, right? And, you know, they've been told that they're just looking for drugs for their pain, or their pharmacist, you know, is questioning their pain relative to their buprenorphine and their dose, or whatever it is, they come to us with all of that. And so I think it's a great point that people don't self-disclose, because they think that either they're not going to get treatment for it, or maybe they think that we're going to assume that they're asking for a full agonist opioid, or that we're asking for them to do something specific with their buprenorphine, or, you know, I think that's or they're just not going to get, or that we're not the right place for help for it. I think that's a really important observation. Yes. And I think, thank you, David. But yeah, I think that's a great, I'm not trying to pick on you, but I really appreciate your point. So could you mind unmuting and saying what you mean?
Yeah, so it's interesting because I came to addiction from treating a bunch of people 10 years ago. And I see less of them, and I wonder, I think there is some we don't ask enough, because initially when you do this, you're afraid to ask because they're going to ask you for stuff. But I also think being in these programs, the way they're designed, especially I work with a lot of women addiction, they get a lot of support, and I think that helps them get better. I mean, they tell me everything, their sexual dysfunction, their shame, their trauma, but they rarely tell me a lot about pain, and we could ask more directly, but I think some of it's that pain's complicated, and as they get better, I think they cope. I don't know if their pain gets better, but they cope with it better, I think. So anyway, that's what my comment was.
That's a really helpful comment. Thank you, David. Because I mean, and like, I think part of what you're saying too is that a lot of the CBT type skills that, you know, you use for these other mental health comorbidities are also the same skills that pain CBT is composed of. And so, so there's a lot of overlap, and it's very transferable. But yeah, so that's a really helpful comment. Thank you. Next slide. And we're going to talk about some of that in a second. Next slide. So yeah, so we've talked actually about a lot of this. So I'm just going to keep going. We've talked about most of this. Next slide. We talked about this. Yeah, so I think just acknowledging that chronic pain is real and a treatable disease goes a long way with patients with chronic pain too, because I think, you know, a lot of folks have also been told that it's not, and just empathizing with people. We're very good in this field at using person first language. And I think, and, you know, a lot of patients will tell me, like, you're the first person to ever actually sit down and talk to me about my pain. Most of the time people gloss over it or are not receptive to discussing it. So just being there for that discussion is, you know, like more than half the battle. Next slide. Okay. So now management, non-pharmacologic approaches. So next slide, we'll just get right into it. So this recent really excellent systematic review focusing on 4 main pain conditions and non-pharmacologic approaches that are evidence-based. So for low back pain, exercise therapy, psychological therapies, and we'll get into what the specific ones are that have the best evidence behind them in a second, and acupuncture for neck pain, manual manipulation for knee pain, Tai Chi, and for fibromyalgia, exercise, mindfulness, acupuncture, multidisciplinary rehab. So already you're seeing some patterns emerge here. Next slide. Yeah, and if you want to look at it from the other point of view of the non-pharmacologic approaches, which ones have the most evidence base? So psychological interventions, it's really CBT. So that's why I was saying a second ago, like CBT is really cognitive behavioral therapy. What's that? Oh, I thought someone said something, or maybe somebody just got really energized by the mere mention of CBT. But cognitive behavioral therapy is really has the strongest evidence base behind it. And then there are things that are kind of derived from CBT, like pain self-management, that are ways of manualizing CBT and getting it out there to the masses, where a psychologist, it doesn't have to be a highly trained psychologist or social worker, but it could be somebody just trained to pick up a manual and communicate well. And then acupuncture for chronic low back pain and knee OA. And I looked in West Virginia Medicaid, it looks like acupuncture is not covered. But it looks like psychotherapy is, and it doesn't say exactly what psychotherapy is, but maybe in the chat you guys can talk about what is actually covered, because I get the sense that most of the coverage that's of interest here probably is Medicaid. Next slide. So approaches that have been tailored specifically to individuals with OUD and pain, mindfulness-oriented stress reduction, mindfulness-based CBT. And then I'll talk about this more in a second. I'm happy to answer questions, but we are going to be launching a study at WVU where we're going to be looking at this manualized version of cognitive behavioral therapy called pain self-management. That is, we specifically tailored it to people with opioid use disorder by doing interviews of people at WVU and a few other sites. And this is the first time this has been tried in people with OUD, even though pain self-management is really pretty standard in other chronic pain populations. And this is something that we're going to be trialing at Morgantown Code and WVU East. So very excited about that. Next slide. Okay, pharmacologic approaches, and we'll talk about BUP in a second. So we'll just go right into it. Okay, these are them. We'll go on each one of these. Next slide. Oh, next slide. My animations are getting the best of me. Next slide. Uh-oh. It's frozen for me. Oh, okay, I see it now. Sorry, on my screen it's frozen, but now, can you go back a slide?
Yeah, are you still frozen? Did you need the slide with the highlighted items on it?
Go back one. I'm good. Go back, go forward, Sorry.
That's fine.
Highlighted is good. Okay. All right, now my big screen is finally caught up. Sorry about that. Highlighted items. Okay. So yeah, SNRIs. So duloxetine is the one that's been tested. That's why it's the one that's gotten FDA approval. So duloxetine has FDA approval for fibromyalgia, peripheral neuropathy, and quote unquote musculoskeletal pain, I believe is how it's worded, which is basically low back pain and knee osteoarthritis, because of these studies that are listed here. It's not to say that other, SNRIs wouldn't work, or, another antidepressant might not work. And what I always tell people is if somebody has severe depression and there's something that's worked for them in the past, it's very reasonable to start with that first. But if not, then I usually start with duloxetine if they're, willing to try that because of these studies. Next slide. SSRIs and TCAs have pretty low quality evidence for chronic pain, but people, for chronic pain specifically, but certainly for somebody with neuropathic pain, trying amitriptyline is totally reasonable. We do that all the time for tension headaches. Amitriptyline, that's totally reasonable, certainly for IBS. But those are for generally a little bit further down the list. Next slide. Okay, gabapentinoids, postherpetic neuralgia and fibromyalgia are the things that these have FDA approval for. Evidence really does not support their use in other conditions. They're used off-label all the time, thanks to a whole lot of good drug company marketing, and patients swear by them. But again, this is really off-label use. Next slide. Lots of adverse events in studies. It seems like the safety issues are a little bit less with gabapentin and buprenorphine combined than with gabapentin and full agonist opioids combined. And SNRIs and TCAs have lower numbers needed to treat, and they're better tolerated. So I'm hating on gabapentinoids just a little bit. People who know me know that this is my thing, to hate on gabapentinoids for this reason. Just the evidence base is not where the marketing is. Next slide. NSAIDs mainly studied in low back pain. Topical NSAIDs reasonable. Next slide. Acetaminophen, like very little evidence. Why do we do this? Next slide. Muscle relaxants. So we just completed a systematic review of this, and there's so little evidence for this. We do this all the time. Lots of side effects. People in glass houses shouldn't throw stones. Like, we all do this. I'm not going to say I don't do this, but there's just very little evidence. Next slide. So bupe. So I would love to hear from people about the practice of splitting buprenorphine and being on doses higher than 16 milligrams. And I hope people are giving me grace about the time, because we're having a conversation. So this is kind of part of the Q&A. Is this part of the Q&A? Can I do that, Elizabeth?
Yeah, absolutely.
Okay. All right. So where are people at with split dosing and dosing greater than 16 milligrams? Because this is where, people really start talking about bupe for chronic pain. I think this is where the cutting edge is here.
Yeah, please feel free to unmute, chat.
Yeah. Right. Yeah, I agree. The analgesia is sure. Feel free to unmute if you would like. Not trying to pick on you, Dr. Hirschler, but if you would like. 95% of our clients split dosing. Yeah, I think if you talk to people about this, some people are like, you don't want to know what they're doing. They're taking little pieces throughout the day, but ideally like Q8 hours. Split helps. I agree. Above 90%. Yes, I agree. 100. Yeah, I agree. Most people split, very little on more than 16. Okay. But yes, let's say everybody is splitting their dose, or many people are splitting their dose. Yeah. Yeah. Okay. Next slide. So lots of splitting, maybe a lot less on the high dose. Okay. So, yeah. So it seems like buprenorphine does improve pain. In fact, in people with opioid use disorder, split dosing is very common practice, although the literature is limited, but like it stands to reason. Dosing greater than 16 milligrams, there's very little literature, but there's some argument for biological plausibility in the high potency synthetic opioid era, that maybe people need higher doses, with fentanyl. And right. So Medicaid requires PA for 24 milligrams. And I understand from reading your state, basically from reading the legislation, that there is a statement in there about needing documentation for greater than 16. as well. Yeah, and no ceiling effect for analgesia. Exactly. So the more you give, the more it works, ideally. I mean, obviously there's, I've seen people give more than 32. I have not personally done it more than once, but generally people stop at 32, but right. So you can keep going up. I agree. Next slide. And I will say that, I'll get to that in a second. Hang on one second. So higher buprenorphine doses and other outcomes. So I think there are some observational studies that suggest that when you get to these higher doses, because people are doing these higher doses, so you can look in claims data and study what happens when people do these, prescribe these doses between 16 and 32. And it looks like there's some signal about retention in MOUD, which obviously, retention in MOUD, we know improves, reduces mortality and reduces overdose. There's some data about decreased return to use, and we are working on a paper that suggests there's some decreased health services utilization as well. Next slide. So just to mention that, so like given all of that, I would say there's some, real equipoise. In other words, like, we don't really know, but there's a reason to study what happens when you go over 16 milligrams for opioid use disorder and pain. Like, does this really work? And should we be trying to push not just West Virginia Medicaid, but I don't know if you guys know this, but in the state of Tennessee, it is illegal to go over 16 milligrams. So I've been doing some work with Tennessee, and I was shocked to find that out, that it's actually illegal. So, should we be pushing for policy reform? Because if it's true that going to higher doses helps with pain, helps with retention, then it should not be illegal in any state. And we should not be requiring PAs, But if it doesn't help, then we shouldn't be doing it, right? Because why should we do something that doesn't help? We should be doing that for anybody. So we're actually doing this study of pain self-management, and we're also in that same study randomizing people to what we're calling patient-oriented dosing, which means going up to 32 milligrams, and it's split dose. So you can split the dose up to 4 times a day. And we're looking at pain and retention outcomes. And we're doing this all over the country, and WVU, as I mentioned, is a site. That's great. And we're actually, and for this study, WVU is basically waiving the PA and just allowing people to go up to, or sorry, I shouldn't say waiving the PA. Erin, correct me if I'm wrong. They are allowing people to go up to 32 milligrams with a PA. Now I'm blanking.
We've got exemption that will allow study participants to receive above higher doses of buprenorphine for a set period of time. And I think we still have to go through the prior authorization, but we'll do that through study staff.
Yeah. So this will be, a real look at this issue. Yeah. And I like your point, David. Yeah. Pain is complicated. Amen. Next slide. We're almost done. And just quickly, some common concerns. Extra medical use, which includes recreational misuse and diversion. So basically, recreational use being intentional, non-therapeutic use for the purposes of achieving a desirable psychological, physiological effect. Recreational use is much less common with bupe. It just doesn't work as well. Next slide. Uh-oh, sorry, my computer is not cut up. Misuse, use without a prescription in this context, and diversion, basically, the unauthorized rerouting or misappropriation of prescription medication to someone for other than for who it was intended, including sharing or selling. Next slide. So why do people divert their supply? Profit, helping others, saving some to get high, not needing the entire dose. But why do people misuse? Basically buying diverted supply, lack of access, right? So avoiding taking other opioids and managing withdrawal. This is a this is a problem of, we don't have enough of us. And is this the right thing? Is this the quote unquote right thing to do? No, but desperate people do desperate things. And so, I wouldn't want to not give people up to 32 milligrams if it works, because we haven't caught up with the supply of us. So I think we really need to see if this works, and fix this problem at the same time. Next slide. And the harms with misuse, much less with bupe than with full agonist opioids, which is what would happen if there wasn't the bupe available. Next slide. Woo, that was a lot. So we have 2 minutes left, but we've had a great discussion already, which I truly appreciate. What other comments, questions, words of wisdom do people want to share?
I just want to say thank you very much for doing this. This is wonderful. I really like the questions scattered throughout to try and engage with everybody. So I appreciate that. But yeah, does anybody have any comments, questions?
Procedural approaches to chronic pain. So there was a great systematic review about this. It's probably like 5 years ago now, but there's not been much since then on this, by Roger Chow. And most of the procedures that people are sent for are not evidence-based. So trigger point injections, epidural steroid injections, pumps, like intrathecal pumps. They're just, sorry, I don't know if there are any anesthesiologists on this call that I'm mortally offending here, but it's not to say that they don't work for anybody. It's not that, like with anything else, it's not true. And it's not to say that once, there's no role to try them, but they're not like the first, second, or third line, generally speaking. I think where I use them the most is when somebody has a very localized area of pain, where opioids are, I'm really trying to avoid full agonist opioids. I use them a lot in my patients with cancer. As I said, I have a cancer clinic. And, in those folks, I have a lot of folks who need like celiac plexus blocks for their pancreatic cancer to get them some relief, have a very short prognosis. I think that's where I probably use them the most. But like for chronic low back pain in a 30-year-old, like that's not, something I reach for in my top 4 or 5.
Hey, Dr. Merlin, I sort of have a question. If morphine milligram equivalents, 1 milligram of buprenorphine equals about 30 milligrams of morphine. Do you agree with that?
I think that's difficult. So I usually, I don't know, what's your follow-up to that? What's the, am I being, I'm joking you. I don't know you, but like, am I being set up for something? What's the next part of your question?
Well, my point is that it's extremely effective for pain. So if you're given more than 16 milligrams, you're given quite a bit of dose for analgesia.
Yes. Okay. Yes. Yes. I see what you're saying. So I would say, right. And Butrans patches and, microgram, but there's a different mechanism for that. But I hear what you're saying. I will say this. What I generally teach on this is that there is really no equivalent, like there are numbers published, but there seems to be no, in clinical land, there seems to actually be no equivalency. Like I have had people who are on 2 grams of morphine a day, 3 grams of morphine a day, who use 50 bags of heroin a day, whatever that means, 50 bags of fentanyl a day, who do fine on, 8 BID. And you're just like, how is that possible? But I think it's complicated, as somebody said earlier, I think it was David, because there's hyperalgesia involved. I think some of the time, like, do they really need all that? Some of the time, like, I mean, I guess you're sort of asking it from the other perspective, like, 1 milligram of buprenorphine should be plenty. But I mean, I don't know. I don't find that I've never found equivalency to be a helpful way to think about buprenorphine and morphine and equivalent. You know what I mean? It doesn't seem like that's the case. But I don't know. I mean,